Good morning. I am Dr. Jessica Ryniec from CCR and Fertility in Boston, and this morning I am going to talk about the fertility evaluation. Not sure how long this is going to last. I'm going to try to hop on, although I am on call at the end of it live so that I can answer any questions, but let's just get started. So when does the evaluation actually start? Is it with the tests? Is it with the first phone call? It is actually during the new patient visit. So your medical history is actually the start to your evaluation, and it's one of the most important pieces of the evaluation because your doc will use this history to make a comprehensive testing plan for you, and also may even start formulating some ideas about what might be going on, even from that first visit. And so you will spend that consultation talking about your past medical history, past surgical history, menstrual history, if applicable, obstetric history, if applicable, and urologic history, if applicable. And then you'll go through your medications, family history, social history, and anything else that you think might be pertinent to your care. Of course, we are not expecting this to be the topic of the conversation today. And so what about actual testing and fertility evaluation that you're thinking of that I'm going to talk about today? So when it comes to the fertility evaluation, there's really 5 main areas that we need to investigate. Infertility can be caused by a number of different factors, and looking at these 5 things will give us a pretty good idea for most people what might be going on. So what that includes is the eggs, and for that we do ovarian reserve testing. We look at the sperm, and for that we do the semen analysis. We look at the anatomy, which includes the uterine cavity and fallopian tube testing, the hormones, which include thyroid, prolactin, and maybe some other testing, and preconception testing or pre-pregnancy testing, things that might not actually be related to fertility, but are important to look at prior to pregnancy. So let's talk about the eggs first. What is ovarian reserve? This is the measure of the number of eggs that you have right now. A person is born with all of the eggs that they're going to have, and that number and the quality of the eggs, unfortunately, goes down as we get older. So seeing what your ovarian reserve right now is important in a fertility evaluation because it can predict how you would do with treatments like in vitro fertilization. I like to think about ovarian reserve as if it's a bank. So you have this whole bank of eggs here, and every cycle, your ovaries will recruit a certain number of those eggs to the surface, which will be kind of like your monthly withdrawal. Of those eggs, if everything is happening as it should be, typically you get to spend 1. That 1 egg gets the signal to mature, eventually ovulate, and unfortunately the rest that you don't spend from that monthly withdrawal don't roll over. So you lose them. This process repeats every month or every cycle until we reach menopause, when the number of eggs is so low that we stop ovulating, or when our bank account runs out. And unfortunately, this monthly process is not stopped even when you're not ovulating. So when you're using hormonal contraception, pregnancy, and breastfeeding, even though you're not ovulating typically at those times, this process is continuing. This is a graph of what our ovarian reserve looks like, and you can see that actually before we're even born is when we have our highest number of eggs. That already drops by the time we are born, still runs down before we even start ovulating, and then it slows down over time after that point. And what we need to do when we're doing the ovarian reserve testing is figure out where you are in this process. So the ovarian reserve testing has kind of 3 main parts typically. There is anti-Müllerian hormone, or AMH. We will also do typically a set of hormone levels on the cycle day 3. That's FSH and estradiol. And we will also do an antral follicle count via ultrasound, where we can look directly at the ovaries and get an assessment of what we're seeing. Anti-Müllerian hormone is a hormone that is made by the cells that support your eggs. This hormone is nice because it can be drawn at any time in the cycle, so there's not a cycle dependency to it, because it's always around. And it's a good marker, a good direct marker of what your resting follicle count is. I always like to note to patients that AMH can be suppressed by birth control, pregnancy, breastfeeding, because sometimes if people are doing this for something like egg freezing and they're on birth control, they might see lower numbers than they should be for their age, and that might just mean that they're suppressed. The cycle day 3 hormones are a little bit more complicated than AMH. These don't really give us a direct look at what your ovarian reserve is, but give us more of an idea of how your brain and ovaries are talking to each other. So cycle day 3 is typically considered the baseline of your cycle. And at that point, follicle stimulating hormone starts coming from the brain to tell your ovaries to make or mature an egg. As the egg is maturing, the ovaries make estrogen, and then that estrogen typically goes back up to the brain to turn off the follicle stimulating hormone. These hormones fluctuate in relation to each other and throughout the menstrual cycle and can tell us how the brain and ovaries are talking to each other. As I said, as our egg count goes down, the brain has to work harder to stimulate the ovaries, and so follicle stimulating hormone goes up. And that is why sometimes it's concerning to see a higher FSH level on the 3rd day of your menstrual cycle. Since estrogen suppresses FSH, doing the two of them together helps us interpret, because if you have a high estrogen and your FSH is low, that's less indicative that everything is okay, because the FSH is probably just low because the estrogen is high. And that's why we need to have those two levels together. And then you can see there on the bottom, those are the hormones of the menstrual cycle. So you can see those are changing throughout the cycle. And what's really important is that we look on day 3, because that will give us the most information. Sometimes, depending on where you are, you may need to do an additional test for ovarian reserve called the Clomid Challenge test. This is not a test that we typically use clinically anymore, but is sometimes required by insurance companies. And it's very similar to this, where you do the cycle day 3 hormones, then you take Clomid, which is a fertility medication, for 5 days, and repeat those hormones, FSH and estrogen, on day 10 to see how your body responded. I didn't include that in this presentation because some people don't have to do that test. It all just depends on whether you have insurance coverage, where you are, and if your insurance company requires that test. The last piece of ovarian reserve testing is the antral follicle count. And this is when we do a transvaginal ultrasound, typically, to take a look directly at the ovaries and see how many follicles we can see at one time. These antral follicles that we're seeing is a snapshot of your ovarian reserve. It's not indicative of your bank of eggs, but more of that monthly withdrawal. So that number of follicles we can see on the ovary is your monthly withdrawal, essentially. And one of those follicles, typically if you're ovulating, will grow, release, and ovulate. And the rest of them, as I said, don't roll over, so they die. And then depending on your size of your bank account, your withdrawal may be larger or smaller. And that is why the antral follicle count helps us. The antral follicle is higher if the overall ovarian reserve is high, and lower if the overall ovarian reserve is low. I just want to pause and say something that I think is really important and misunderstood about ovarian reserve testing. What's really important to know is that a low ovarian reserve doesn't necessarily mean that it's going to be harder to get pregnant. And it's not typically a cause for infertility unless it's so low that you're not ovulating anymore, which is a whole different issue. And it also doesn't judge your ability to get pregnant either on your own or with kind of the lower level fertility treatment options. What ovarian reserve is more important for is prediction of how many eggs you might get for an IVF cycle, and helping us to make sure we are getting the right protocol for you to maximize your success if you're doing something like IVF. Because on your own or with intrauterine insemination or ovulation induction, you're typically still only ovulating one egg at a time. So the total number of eggs you have really doesn't matter as much, because everything depends on that one egg. Whereas with IVF, our goal is to get many eggs. And so if you have a lower ovarian reserve, then that can impact that process. Now, the ovarian reserve, in addition to helping us decide, what meds and protocol we might use for IVF and helping you counsel you on what you might expect from a single IVF cycle or set you up to, realize maybe it'll take more than one cycle, can also help you decide what treatment options you might want to do. Sometimes when someone has a low reserve, they're more likely to want to get to something more aggressive sooner rather than later, to help freeze additional embryos that they might not have in a few years. But really important to know, like a low AMH, low ovarian reserve doesn't cause infertility, again, unless it's so low that you're not ovulating anymore, but is really more of a complicating factor. What else do we need to know about the eggs? Egg quality. So that, as I said, is something that also goes down over time. Unfortunately, there is no test for egg quality. And so typically we assume it based on age. And this is just a table here of chance of having a euploid or genetically correct embryo compared with the chance of getting an aneuploid or genetically incorrect embryo as age increases. This is some data from CCRM in 2018 and 2019. You can see, in the early 30s, it's pretty stable. And then, once you're 37 and older, it starts to decline a little bit faster. So this is kind of more just assumed based on age. Sometimes we do get information about egg quality during treatment, but there is unfortunately no test ahead of time. So that was really all of the testing that we have for the eggs. So now we have to go to number 2, which is the sperm. And the sperm can be involved in 30 to 40% of cases of infertility. And so, very important piece of the puzzle. The way that we test the sperm is through the semen analysis. And unlike eggs, sperm can be and are made continuously unless there's a sperm factor contributing to infertility. So much sperm, in fact, that in a normal sperm producing person, there's 120 million sperm produced per day, which ends up to be about 5 million per hour, about 83,000 per minute, and about 1,000 sperm per second, which is just insane that anything else is going on in the body with that much sperm production and energy devoted to that. So what is the semen analysis? The semen analysis is typically a test where a collection is performed either at home or in the office, and then that sample is evaluated under the microscope. There are a number of factors that are looked at. These 4 are typically the most important. So the volume is the total amount of ejaculate, and the normal values are there, about 1.5 to 5 milliliters. The concentration or count is a very important piece. That's the number of sperm, and the concentration versus count are just a different way to look at it. Motility, which is the movement of the sperm, that assesses how well the sperm moves and should be at a certain marker level. And then morphology, which is how the sperm looks. If you'll see there that normal is only 4%, which means that we have very low expectations for the shape of sperm, probably because it's mass produced, so there's a lot of error. The other important thing to note about morphology is that it's a very subjective test, meaning whoever looks at it and does the test is looking at 100 sperm and picking out the ones that look normal. Some people are a lot more strict than others, which means in some labs, a low sperm morphology might be really common, whereas some people might be very nice and a high sperm morphology might be more common. So I always caution people to ask, how the morphology for you, measures up to the typical morphology measures you're seeing in the lab the semen analysis was performed. Another important thing is that typically if the morphology alone is an issue, that is less of an impact on fertility than if the concentration or motility are an issue. So something else to kind of keep in mind. With the semen analysis, you also will get some other values. These are typically less important in most people. However, these different things here, the pH, white blood cells, fructose, liquefaction, viscosity, and agglutination, those can be helpful if there are abnormalities in the more important factors, or if these are very abnormal in directing us towards a potential cause for why the semen analysis is abnormal. So looking at these things help us interpret and kind of try to find the source of what might be going on. And then finally, the sperm evaluation may also involve a urology referral. That is a reproductive urologist specifically, who can potentially do hormonal blood testing, a testicular exam, or ultrasound or imaging of the testes to see if there are any abnormalities of note, again, to help guide treatment of male factor. Okay, what's next? The anatomy. So this, again, is the uterus and fallopian tubes. Obviously, we looked at the ovaries a bit with the ovarian reserve testing, but this is looking kind of more directly at functional anatomy. Why do we need to look at this? So the uterine cavity is where an embryo in pregnancy implants and grows. So we need to make sure that there are no fibroids, polyps, scar tissue, or other uterine cavity abnormalities, such as an abnormal shape to the uterus, that impact implantation. We also need to know about the fallopian tubes because that is where the sperm and egg meet and fertilize, and that is the pathway from the pelvis into the uterine cavity where pregnancy occurs. And so we need to make sure that they're open, that they're normal caliber and functioning normally to assess fully the fertility. There are a number of different ways that we do this. The first or most commonly thought about, I think, is the HSG or hysterosalpingogram. This is a test that looks both at the uterus and the fallopian tubes. It involves the injection of contrast material into the uterus or dye, and that goes through the cervix, and then you use an X-ray to see the uterus and tubes. And you can see down at the bottom, there's an example of that where the white is the dye that went into the uterus. The uterine cavity is that triangular portion up there, and then the fallopian tubes are those little narrow strings that come off of the two corners, and you can see the dye there towards the end of the tubes. The HSG test is an excellent test for visualizing the fallopian tubes. It can demonstrate if there are any irregularities within the cavity of the uterus, although less sensitive for that compared with the tubes. And so this is a good option for looking at both. The other option that is most commonly used is something called the HICOSI or hysterocontrast salpingography. This is very similar to the HSG test. Instead of using contrast dye and an X-ray, though, it uses saline and a pelvic ultrasound. This actually shows us the cavity of the uterus a little bit better than the HSG. You can see the difference here where that triangle shape is really clear that there's nothing pushing in there. And it also can visualize the fallopian tubes and determine whether or not they are open. And finally, the last way that we typically will look at the anatomy is a hysteroscopy. So this, unlike the others, is a direct visualization of the inside of the uterus. And you can see down here in the little cartoon image, there's this camera that is guided through the cervix into the cavity of the uterus. And then there on the right is the visualization that we're able to see. This is the most direct way and clearest way to see the cavity of the uterus. However, it does not tell us that the fallopian tubes are open or closed. We can see where they insert into the cavity, but we can't see that they are functioning. This would potentially be more important if there are any concerns on the HSG or the saline ultrasound test that there's something in the cavity, or if someone has a high likelihood that something might be going on within the cavity, like heavy bleeding or prior procedures within inside the uterus or inside the cavity of the uterus, like a DNC, prior pregnancy losses, things where we might want to just a little bit of a closer look inside the cavity. Oh, and then this is actually truly the last piece of information that we get when we're doing the anatomy, and that's the mock embryo transfer. This is typically done at the same time as the above procedure, so it doesn't feel like a different test to you, but it is important to confirm that we are able to easily get through the cervix for when you eventually do treatment. So basically, one of these thin catheters that you can see there on the left of the screen is inserted through the cervix into the cavity of the uterus. These catheters actually can be used for the HSG or the saline ultrasound, which is why, sometimes you might not realize that this is a separate procedure being done. And what's important about it is that you can see on the right side of the screen that cervixes and uteruses or uteri do potentially have different directions that they extend. And so this mock embryo transfer prepares us for IUI or embryo transfer for you so that we're guided and know if there's anything that might be difficult about it. All right, moving on to the next, which is hormones. There are a number of different hormones outside of ovarian reserve hormones that we test through this process. And I'm going to talk about, the most common ones that might be involved. So there is the thyroid. Thyroid hormones are essential for the normal functioning of the reproductive system and help regulate the menstrual cycle and ensure the proper development and release of eggs. Typically, what is tested for the thyroid is thyroid stimulating hormone, or TSH. If it's abnormal, you may have additional thyroid hormone levels drawn, such as the thyroid hormone itself. You might have heard of T4 and T3. Sometimes we'll look at antibodies against the thyroid, but a TSH is most common as an initial screening test. The results of this can show that you have an underactive thyroid, an overactive thyroid, or you could have something called subclinical hypothyroidism, where your body's actually making the proper number of or the proper amount of thyroid hormone, but for some reason that TSH is either too high or too low, and sometimes that may indicate a need for treatment in the trying to conceive or pregnancy setting. The next hormone is prolactin. Prolactin is typically a hormone that is related to breastfeeding and lactation. It's made by the pituitary gland, the same place that your FSH and LH are made, and it plays a role in regulating various bodily functions, including fertility, mainly with the luteal phase. Typically, prolactin is pretty low unless you're pregnant or breastfeeding. If they're too high when you are not pregnant or breastfeeding, that can impact your fertility. It might have really subtle impacts. You might not notice irregular periods or anything through that. However, definitely an important thing to look at. And if it's too high, you may be instructed to start medication. And the last hormones that we'll talk about in the endocrine testing are the androgens. And these are a group of sex hormones that include testosterone. Often it is more related to masculinity and sperm, and it is present in both male and females. However, I don't know why I wrote that twice. I probably had something else that I was meaning to write, but I guess the point is there that everyone makes testosterone in some amount. Most people will not have their androgens tested in their initial workup. However, if in that history there are any signs or symptoms of PCOS, polycystic ovarian syndrome, or any other signs like hirsutism, which is excess hair growth, acne, anything like that, androgens may be added to your initial workup as well. And that is really kind of where I'll stay for the endocrine evaluation, which brings us to preconception testing. And as I said, this is not typically truly fertility, but is important because, our goal is to help get you pregnant. And these tests are important for someone that is thinking of or trying to conceive. The first is genetic carrier screening. So this helps your understanding of the risk of passing on certain genetic disorders. Some people carry recessive genes, but don't actually have the genetic disorder themselves. These individuals are called carriers. Many people carry something. The goal or the hope is that you don't carry something that your partner also carries. There are also dominant genes, but those typically you see either in yourself or in your family. So those are something that's visible, whereas these recessive genes can be hiding and not pop up until, two people that carry the same recessive gene have a child, and that child potentially is affected. So if both partners are carriers for the same genetic disorder, then there's a chance that their child could inherit both copies of that and be affected. The results of this screening will tell you whether you and your partner are carriers and what the risk of having a child might be. And then that helps you to make informed decision about your family planning, such as considering IVF with PGTM genetic testing, or do testing during pregnancy, or just prepare for the possibility that your child could be affected by this, or even exploring other family building options, like donor egg or sperm or adoption. These genes that I'm talking about, common examples would be cystic fibrosis, biomuscular atrophy, congenital adrenal hyperplasia, but there are hundreds that we're able to screen for with a blood test. The next thing that's important in immunity testing is to determine whether you are not or are not immune to certain infectious diseases. And if not, to recommend vaccines that would protect you and your baby during pregnancy. These are typically infectious diseases that you can't get a vaccine for during pregnancy. So it's important to know ahead of time so that you can protect yourself. Some of the ones that we test commonly is rubella, varicella, which is chickenpox, measles, mumps, and rubella. These viruses or infectious diseases that can have serious consequences if you are infected in pregnancy and do not have immunity. And so we like to look at those ahead of time so we can recommend if you get a booster shot or protection so that you can have a healthy pregnancy. And finally, we also do other infectious disease testing to make sure we know what might impact your baby. These are typically things like hepatitis B, hepatitis C, HIV, syphilis, gonorrhea, and chlamydia. This is also helpful if you end up doing something like IVF, because we need to assess the risk of people that are taking care of you too. So this is kind of the end of what the testing is. I wanted to spend a little bit of time talking about how to prepare for testing, because I find that, oftentimes as providers, we're great at explaining what the tests are and what they're for, but you don't always necessarily get the info about how to prepare. You should, hopefully, when you schedule the appointments, but these are just some quick tips, and then we'll be done soon. So how can you prepare for blood work? Always want to make sure that you are well hydrated. Definitely want to ask ahead of time if you should be fasting or not, because certain labs should be done fasting. And you don't want to have to come back if you don't have to. You definitely want to let the phlebotomist know if you're on any blood thinners, because then you might bleed more during the blood test. And then you also want to let your phlebotomist know, if you've ever fainted before during a blood test or have issues with blood tests. That way they can position you differently ahead of time to lower the risk that you might pass out or have issues with the blood draw again. Similarly to that, if you're anxious about it or have had any other issues during blood draws in the past, you want to let the person know that's drawing your blood so we can set you up to not have that experience. How about the ultrasound? So how to prepare for the ultrasound? You want to confirm ahead of time whether the ultrasound will be transabdominal or transvaginal. That both impacts how you might prepare for it, but also, gets you ready to know, like, are you going to have just a probe right on the tummy, or is something going to be going in the vagina? Just to prep you kind of mentally as well. Part of this is knowing whether or not they want you to have a full or empty bladder. Typically for transabdominal ultrasound, we can see better when there's a full bladder. And when there's a transvaginal ultrasound, we can see better when there's an empty bladder. So I always recommend people confirm that. And then the last piece of preparing for a ultrasound, I would say definitely make sure your provider knows if you've had difficulty with transvaginal exams or pelvic exams like pap smears in the past, because everyone should be approached for these exams with sensitivity. But there may be ways to help prepare you differently if you've had a problem with these before. And always know that you are in control, even though we want to get this information, you're not forced to do any of it. And you're definitely in control during the procedure too, even though definitely feels like you're not. And then the last thing I wanted to talk about for how to prepare for testing is the uterine cavity and fallopian tube evaluation, because I find that this is the most intimidating one and many people are very nervous about it. Before the day of the procedure, you might want to ask your doctor about pre-medication. This, I think, is like a very pervasive feeling or sentiment that this can be a very painful exam. I will say, having done hundreds, if not over 1,000 of these, that 90% of people are totally fine, have mild cramping, and are surprised that it's not anything like what they think. Some people feel nothing. And then there is a small subset of people that are very uncomfortable with the exam and have pain. I find that unfortunately, the people that are very uncomfortable and have pain are the ones that are on the internet talking about it. So I would definitely recommend avoiding that. But if you're concerned or anxious, ask your doc about what you could take ahead of time. Some will recommend NSAIDs like Motrin, Advil, ibuprofen. I always offer my patients Valium to help relax them and relax the pelvic muscles so that it might be a little less uncomfortable for them. So ask if that's a possibility if you're nervous. Most of this is not done with anesthesia, unfortunately, because it's a very quick exam, and we don't want to put you through the risk of having anesthetics for something that the majority of people can tolerate very well. Again, you are in control, so if anything feels off or you want to stop, your provider should do that. When you get to the office for this procedure, you'll probably be on an examination table, very similar to like when you're getting a pap smear, and then a speculum will be inserted. Again, very similar to a pap so that we can visualize the cervix. Cervix and vagina typically will be cleaned with betadine, which is that brown cleanser stuff. So you would love to have a pad afterwards. We then do the mock transfer potentially and insert a catheter. Sometimes people feel a small cramp with this. Many people feel nothing. And then we're going to inject the contrast or saline. And that's the part that if you're going to have discomfort, you will experience at that time. Typically lasts about 30 seconds. We are either looking with X-ray and taking pictures or looking with the ultrasound and taking pictures. And then once we see what we need to see, we remove the catheter and the speculum. And then you recover, which, there's no real recovery to the procedure. Sometimes people will have spotting or discharge from the betadine plus the dye and the saline. But many people go back to work. You don't need to take the day off. And it is a pretty straightforward recovery. If it is uncomfortable for you, most of the time, once you get up and walk out of the room, you are feeling just fine. So hopefully this was a comprehensive, if not fast-paced, talk about what fertility testing might look like for you and how you might prepare for the fertility evaluation starting from that very first visit. And hopefully if I am done with retrievals on Saturday, I will be online with you now to answer some questions. If not, you can always reach me at CCRM. I also am very active on Instagram and TikTok and do a Q&A every Sunday. So you can always find me there as well. And so glad we have this Resolve New England conference, and look forward to meeting some of you potentially in the future.